Hi, my name is Sanju Dhawan. I am PhD student from Rutgers School of Nursing, and my poster is Factors Influencing Dementia Treatment Seeking Behavior Among Asian Indians Living in the United States. So, Asian Indians are the one of the fastest growing racial subgroup in the United States. Dementia cases in Asians are projected to rise 113% by 2040, and in India, 7.4% above 60, 9 million approximately living with the dementia. Unpaid dementia caregiving in US cost estimate 340 billions. Caregiver they feel significant challenges and barriers, stigma, stress, and which diminished quality of life, caregivers as well as the patient. So there's limited literature available in Asian Indian populations. There's this literature review identifies the factors influencing dementia treatment seeking behavior in Asian Americans using the healthcare behavior model and transcultural nursing theory frameworks. So this is the model which I integrate a framework based on two theories: perceived susceptibility and cultural beliefs. So perceived severity and stigma, perceived barrier and family caregiver giving, perceived benefit and traditional practices, which is common from those picking both models. Cues to action and religious social factors, self-efficacy and trust in healthcare providers. So literature with strategy, we looked into all the database, Sinhall and Medline academic search. Keywords we use for dementia: Asian Indian, South Asians, and you can see all the immigrants and all the. So inclusion criteria we use from 2014 to 2024 articles. Qualitative we had 11, quantitative 3 articles, meta analysis we include the 1 article. And perceived dementia, susceptible to cultural beliefs, basically this population perceive dementia as a normal aging. Cognitive decline considered like as past karma or past deeds, supernatural causes, and they don't want to seek medical treatment. So they feel low perception, lower screening rates in this population. Asian Americans have longer survivor rate after diagnosis, which is 4.4 years compared to other populations. So they perceived severity. This dementia is seen as shameful, threat to family honor, like ijat, fear of they have social judgment, social isolation. They avoid taking family member to the social gathering. They try to seek people are going to judge them. They don't want to disclose the symptoms or seek the diagnosis. Perceived barriers, they are language barriers, culture, lack of cultural competent services, lack of cultural competent providers are available, limited awareness and dementia services delay in this population. Caregiver face like cultural and financial hurdles. Family responsibility, mostly family obligation to provide care to the family member with the dementia, and which is called filial piety, and they avoid seeking informal care. Mostly females, basically gender roles, they bear the caregiver burden. They are supposed to provide the care to the family members. So perceived benefit and traditional practices, preference for Ayurvedic and spiritual healing over the biomedical treatments. That's mostly literature has seen. Help seeking is delayed as stigma, normalization, and uncertainty. Even early diagnosis is valued. They prefer home care because of cultural norms, and they do not trust institutions for because of culturally food and other situations. There's not availability of their spiritual and cultural practices at the nursing homes. So cues to action, sometimes religious leaders they help them to seek like, oh, your loved one has seen the symptoms or problems there, so they believe that they need to make a decision. And bilingual providers sometimes they help seeking, and they understand their linguistic and understand the dementia issues well. So community events basically bring the awareness and help seeking. Family encouragement, sometimes family members living abroad, when they see the changes in their family member, they can see that you need to seek the treatment, and they encourage and basically convince them to take the treatment. Spiritual coping, sometimes prayers, support caregivers emotionally. Self-efficacy and trust in healthcare providers, there we see higher education and acculturation improve the confidence. When people are no longer living in the US and they're highly educated, they have caregiving confidence and they want to seek the treatment. Sometimes they mistrust in Western medicine and reduce the self-efficacy. So language barriers can be sometimes fatalism, basically nothing you can do or this disease, and stigma and lower efficacy, so they will not seek the treatment. So future implications for this literature review, like it will promote dementia detection and culturally sensitive outreach, incorporate traditional beliefs in the care plans, strengthen family centered support. So nurses can offer culturally tailored caregiver services and bilingual education, build the trust through culture sensitivity and understanding. Nursing research culturally study can culturally advantage, and they can explore subgroups these dementia and issues as well. They can evaluate and provide support, evidence, and they can look holistic review with this integrated model and explore stigma and basically subgroups as well. You can scan the QR code for the references and you can reach out to my Rutgers email if you have any questions. Thank you for listening.
My name is Gina Arakel, acute care nurse practitioner at UTMD Anderson Cancer Center. It's an honor to thank NAINA for the opportunity to present at the 5th Clinical Excellence and Leadership Conference. This year's theme, Engage, Educate, Empower, Advancing Nursing Excellence through Practice, Leadership and Innovation, resonates deeply with the mission of our team. The acute care procedure team, composed of highly skilled advanced practice providers, brings extensive experience in interventional radiology, emergency medicine, critical care, and surgery. This expertise allows the team to deliver advanced high acuity patient care in complex hospital settings. The team specializes in performing invasive bedside procedures, including centerline placement, paracentesis, lumbar puncture, and port removal, while managing patients with acute illness or rapid clinical decline. Comprehensive assessments, diagnostic interpretations, prescriptive authority ensures timely evidence based treatment. Beyond procedures, the team prioritizes accurate documentation, seamless communication across multidisciplinary staff, and education for patients and families. Mentorship of colleagues and participation in quality improvement initiatives further strengthens the team's impact. At the core, acute care procedure team advances procedural excellence and drives improved patients' outcomes, a true reflection of the spirit of clinical leadership and innovation. Today, I am going to present my project titled Reducing Femoral Centerline Use to Prevent Class B in Hospitalized Adults. Central venous catheters or the CVCs are widely used in critically ill and oncology patients for chemotherapy, fluid administrations, nutrition, and hemodynamic monitoring. While they are essential, they also carry significant risks, especially centerline associated bloodstream infections or Class B. These infections are serious, leading to higher patient morbidity, mortality, and healthcare costs. Although CVCs can be placed in the subclavian, jugular, or femoral veins, the femoral site is particularly concerning. It has been linked to higher risk of infection, thrombosis, and colonization with drug-resistant bacteria. National guidelines recommend avoiding femoral lines unless no other options exist. But in practice, they are still used frequently, especially in the ICU where rapid access is critical. A local safety review at our institution found 4 Class Bs associated with femoral lines out of 418 insertions between July 2021 and June 2022. This highlighted the need for a focused quality improvement initiative. The goal of this project were therefore reduce femoral CVC utilization by 50% by March 2024, increased adherence to evidence-based catheter site selection, work toward a Class B rate of 0 through system-level changes and education. We conducted a retrospective study using our electronic health record. Pre-intervention period, February to August 2018, before the launch of the Advanced Practice Provider Vascular Access Clinic. Post-intervention period was September 2018 to 2019 April, after the clinic was implemented. There was a follow-up audit which was conducted on July 21 to June 2022 after a safety review. Data came from the procedure logs of central line insertions by the acute care procedure team and from the EPIC for patient outcomes, infection rates, and documentation. Looking at July 2021 to June 2022, a total of 418 femoral CVCs were inserted. By the team, 82% were placed in the ICU, 15% by surgery or cath lab, and 3% by the vascular access procedure team. The average dwell time was shortest in the VAP clinic, at least less than a day, compared to 4 to 8 days in the ICU and other units. Importantly, all 4 bloodstream infections occurred in ICU patients with femoral lines. There are few key takeaways. Shorter dwell times in the VAP clinic suggest that earlier removal of femoral lines reduces infection risk. All bloodstream infections were linked to ICU femoral lines, reinforcing the dangers of prolonged dwell times. Femoral lines were still heavily used in the ICU, largely due to urgent access needs. Moving forward, the implications are clear. We need continued training and competency in internal jugular access, especially for ICU and nocturnal providers, to reduce reliance on the femoral lines. Expanding the access to expert guide-led vascular teams can help reduce the complications. Finally, reinforcing early removal of femoral catheters and adherence to site selection guidelines are essential for reducing long-term Class B rates. In summary, reducing femoral CVCs use in both achievable and impactful. By combining structured site selection algorithms, improved provider training, and system-level support, we can move closer to our goal of zero preventive Class B. Thank you. Have a good day.
Today's topic for discussion is to look into the research insights on South Asian American adolescents' mental health. South Asian American youth face unique mental health challenges shaped by cultural expectations at home and in society. Stigma, stereotypes, and barriers to care often prevent them from getting needed support. Yet, protective factors like family connections, cultural identity, and resilience foster hope and healing. Culturally grounded interventions that respect family values can significantly strengthen the well-being. Understanding the need, South Asian Americans are among the fastest growing US populations, but their adolescents' mental health struggles remain under-recognized. Challenges include stigma, identity conflicts, and academic family pressures. Research and resources are still limited, leaving many without adequate care. Addressing these gaps is a critical imperative. Research purpose. This research aims to synthesize existing findings on South Asian American adolescents' mental health. We explore key risks, protective factors, and barriers to care shaped by cultural dynamics. Our goal is to inform evidence-based, culturally responsive interventions. Together, this work supports great awareness and stronger advocacy for youth well-being. Methodology. We reviewed peer-reviewed studies from 2020 to 2024 on South Asian American adolescents' mental health, bicultural strength, and family dynamics. Influential work by scholars such as Gupta, Iyer, Patel, Mishra, and Shivangi guided the analysis. Themes included bicultural stress, stigma, and model minority stereotypes. Findings highlight how cultural influences shape identity and psychological health. So, the key findings are the prevalence and disparities. South Asian American adolescents show higher rates of anxiety and depression compared to peers, with girls disproportionately affected. Alarmingly, two-thirds do not receive adequate care, worse than the general adolescent population. These disparities reflect both cultural stigma and systemic barriers. The findings call more equitable, culturally responsive support. Bicultural stress. Studies reveal high levels of bicultural stress as adolescents balance family traditions with mainstream American norms. Academic and cultural pressures or major stressor, often leading to cultural dissonance. Many youth feel torn between two worlds, risking isolation and identity conflicts. These struggles directly contribute to emotional stress. Conclusion. South Asian American youth face unique challenges: bicultural conflicts, stigma, identity struggle. Stigma remains a key barrier to open discussion and care. Effective approaches must be family-centered, culturally responsive, and supportive of bicultural identity. Stronger research and validated tools are urgently needed for equitable support. Implications. Culturally responsive care is essential to support these adolescents. Family-centered therapy, peer groups, community-based programs help bridge generational dividers. Interventions should honor cultural traditions while encouraging openness around mental health. With culturally competent professionals, we can reduce stigma, create safe space for youth. Acknowledgement. I especially thank to NAINA for hosting this event and to SAINA colleagues for their collaborations and support. Gratitude also goes to the researchers and community working tirelessly to advance adolescents' mental health. Their dedication continues to inspire progress and advocacy for South Asian American. Thank you for the opportunity to discuss the mental health among adolescents, to have an insight so that we can help our youth to have a better life. Thank you.
Hi everyone, my name is student Dr. Vaishnavi Pandala and I'm also a research assistant under Dr. Panyan, and today we're going to be talking about the management of MASLD and OSHA. MASLD, formerly known as NAFLD, affects 20 to 30% of adults. MASLD stands for Metabolic Associated Steatoic Liver Disease, and it commonly coexists with obstructive sleep apnea due to strong correlation between obesity, insulin resistance, and dyslipidemia. The chronic intermittent hypoxia associated with obstructive sleep apnea worsens the hepatic steatosis and inflammation and fibrosis. Clinical studies indicate a bidirectional relationship between MASLD and OSHA, but CPAP trials show inconsistent liver outcomes, highlighting significant gaps in therapy as evidence. So our systematic review evaluates these OSHA-directed therapies such as CPAP, lifestyle, GLP-1 receptor agonists, bariatric surgery, and hypoglossal nerve stimulation, and their effects on hepatic and metabolic outcomes in adults. So the purposes of our review was, one, to identify and appraise studies of OSHA-directed therapy, to synthesize the effects on hepatic outcomes such as liver stiffness, fat content, aminotransferases, fibrosis scores, and metabolic outcomes such as hemoglobin A1C, lipid levels, and body weight. We also assessed quality and the rate of certainty of evidence using the ROBS 2 and Robbins 1 and GRADE criteria to inform future research and clinical practice. So our methodology was a systematic review following PRISMA guidelines. Our data sources included PubMed, Web of Science, and CENA HL. Our population included adults with masked and obstructive sleep apnea. Our interventions included CPAP, hypoglossal nerve stimulation, GLP-1 receptor agonists, lifestyle modifications, and bariatric surgery. Our comparison groups included no CPAP, sham CPAP, standard lifestyle modification, and we measured hepatic, metabolic, and anthropometric changes. Our risk of bias, we used the ROB2 to assess for randomized control trials and Robbins-1 for non-randomized studies. So we utilized a AI-informed systematic review platform known as Covidence. This helped gather all the data and studies from the databases, and we got a total of 174, and it removed duplicates, which dropped it down to 134, as there were 40 duplicates. Based on title and abstract exclusion, we excluded 94 additional studies. This resulted in 40 studies that we did a full text review for, and we excluded 30 studies from there. And then in the total review, we included 10 studies. So our participant characteristics were predominantly males at 73.5%. The mean age of the participants was between 42.6 and 57.6 years, and their BMI was 26.3 to 35 kilograms per meter squared. Most participants had moderate to severe obstructive sleep apnea. Comorbidities additionally varied, including diabetes from 0 to 43.8%, and hypertension from 21.3 to 81.3%. CPAP adherence was generally greater than 4 hours a night in most studies and ranged from 4 weeks to 3 years. So our first table shows masked relevant hepatic outcomes with OSHA treatment. Based on the liver outcomes table, you could see that there are some mixed effects. Some studies show slight reductions in liver enzymes, but minimal or inconsistent changes in hepatic fat, stiffness, or fibrosis. We see that there is small and adherence-dependent improvements in AST and ALT levels, but there are no consistent improvements with hepatic fat, liver stiffness, or fibrosis over a short to intermediate follow-up period. We also noticed greater biochemical improvements in participants who used CPAP for more than 4 hours a night and with more than 3 months of therapy. Metabolic outcomes are listed in the table below, and the metabolic outcomes included modest improvements in hemoglobin A1C and triglycerides. HDL and LDL remained relatively stable, and the anthropometric outcomes included body composition, and the therapy showed minimal impact on BMI and waist circumference across most studies. We additionally completed a risk of bias for both the randomized and non-randomized control trials, and the randomized control trials indicated low risk to some concerns. However, the non-randomized control trials indicated moderate to serious risk of bias. Our grade certainty was generally low due to small sample sizes, heterogeneity of data, and methodological limitations. And due to the significant heterogeneity in study designs, imaging modalities, outcome reporting, and CPAP adherence, there was limited comparability across the data, and this precluded a meta-analysis, and as such, a narrative synthesis was performed with descriptive statistics such as mean changes, standard deviation, and direction of effect. We have multiple visual tables created with study characteristics, CPAP adherence, type of studies, and clinical outcomes that could be found further in our paper. So what did we learn from all this? Overall, we learned that CPAP generally helps cardiometabolic health but does not affect the hepatic structure alone. As such, for future clinicians, we should be aware that there could be short-term liver improvements, but they will remain tempered, and a multimodal treatment approach is necessary to help this dually burdened population. Combining CPAP, lifestyle modifications, and pharmacotherapy must be necessary to improve hepatic outcomes. Additionally, we would like to start screening patients earlier in liver and sleep clinics to find if there are dually burdened patients earlier and start them on specific therapies. As researchers, we also need to adopt standardized imaging endpoints such as the MRI PDFF for steatosis and the VCTE for fibrosis. We also need longer-term randomized control trials greater than 12 months to truly assess the hepatic remodeling and synergy between CPAP and metabolic interventions. And finally, we need to employ uniform OSHA phenotyping using polysomnography-based AHI and standardized adherence thresholds of greater than 4 hours a night and greater than 70% of nights to really improve the comparability across studies in our data. I would like to personally thank all the contributors to this project, including Clinton Brenner, Dr. Michael J. Brenner, Dr. Teja Chinnapragada, Kevin Guruswamy, Dr. Rewant Kadama Reddy, Alvin Pandian, Dr. Jonathan Stein, and Dr. Vincia Pandian. We would also like to express our sincere gratitude to Ms. Kathleen Phillips, our librarian who helped search for all the articles and pull them for our review. Our references are listed below, and if you have any further questions, please feel free to reach out to me at vp3sm@virginia.edu or Dr. Pandian at vpandian@psu.edu. Thank you so much.
Good afternoon, everyone. I'm Dr. Simi Joseph. This is the research study done at Cook County Health, a cross-sectional study to explore healthcare providers' wellness, current challenges, and gut health. We all know the well-being of healthcare providers is essential for delivering safe, high-quality care. Yet, stress, burnout, and demanding work environments take a toll not only on our mental health, but also on our physical health, especially gut health. The gut-brain axis shows us how closely stress and gastrointestinal health are linked. When stress is high, gut health suffers, and this can impact both our well-being and job performances. So the study focus is exploring the relationship between stress, workplace conditions, and GI symptoms, identifying potential strategies to enhance healthcare provider well-being and job performance. So our study objectives were to assess the prevalence of GI symptoms that affect the well-being of healthcare providers, to explore the association between stress level, clinical practice environment, quality of life, and gut health among healthcare providers, to identify potential interventions to improve gut health and well-being among healthcare providers. So as you can see, the study hypothesis, there's two. One is healthcare providers working in an acute care setting have a high prevalence of gut issue compared to outpatient setting in an academic public health system. Secondly, there is a significant association between stress level, clinical practice environment, quality of life, and gut health among healthcare providers in an acute care setting compared to the outpatient setting in an academic public health system. The study used a framework called biopsychosocial model that highlights the interplay between the biological, psychological, and social factors in health outcomes. So by using this framework, as research examines how gut health issues, stress level, and workplace environments, how collectively this influences the quality of life among all types of healthcare providers. This was a cross-sectional survey study. We invited 1,500 healthcare providers across Cook County Health, including nurses, physicians, physician fellows, and APRNs. Survey ran from December 2024 to January 2025. We used validated tools, DAS-21, which is a Depression Anxiety Stress Scale 21, and a Digestive Associated Quality of Life Questionnaire to assess the quality of care. Collected data on demographics, gut health symptoms, workplace environment, and the quality of life questionnaire using REDCap. The results shows the study included 149 participants, the majority of whom were female, which is 118 out of 30 men, with most being over the age of 45, which is out of 57%, and having more than 5 years of experience, who were 83%. Participation was evenly distributed between inpatient and outpatient settings, with the majority of respondents being full-time employees and registered nurses, which were like 95 out of 149. 126 out of 149 participants, which is 85%, reported experiencing GI issues during the workday. The first hypothesis of comparing the healthcare providers in inpatient and outpatient setting, the prevalence, the analysis revealed no statistically significant difference in GI discomfort or bowel movement issues between inpatient and outpatient healthcare providers, which is kind of an eye-opening for us to know that there's no difference between both areas. Healthcare workers are generally healthcare workers everywhere, so the gut issues is going to be prevalent is the same. Secondly, we also found out that a moderately high prevalence of gut health issues among healthcare providers, and the nurses being mostly affected because most of the data was from nurses. This was consistently across between inpatient and outpatient setting. Another important finding where high stress level were strongly associated with more gut issues. Quality of life also correlated with health problems. So variables that are statistically significantly correlated with GI discomfort and bowel movements were highlighted in the bottom table of the results section. To conclude, gut health issues are common and concerning among healthcare providers, and they are closely linked to stress and work environment. The key workplace challenges listed here contributing to the gut issues in our healthcare institute is limited access and availability of restrooms, difficulty in drinking adequate water, challenges in taking breaks, unpleasant physical activities, unpleasant social interactions. There were high stress levels associated with high prevalence of gut issues in areas where they reported high stress level. So we would like to address these workplace conditions and stress management strategies, which is one of the reasons that we did this study in our healthcare institute. Despite these limitations, despite these findings, our recommendation highlighted the important opportunities. To support healthcare providers, organizations can improve hydration and breaks, ensure water stations, and enforce break policies, enhance restroom access, make sure staff can take timely restroom breaks, reduce workplace stress, offer mindfulness or stress management or mental health support during the high stressful busy day, foster a supportive culture, normalize self-care, reduce stigma around breaks, and educate staff about gut health. By implementing these interventions, we can improve both the health and job performances of providers. Some of the limitations that we found here are self-reported data bias, and the study was, relying on the self-reported responses. So the reporting bias was also is a limitation. Generalizability, the findings are not fully generalizable. We probably need more, research in this area to understand in different healthcare institute how are the, same correlations can be seen or not. Cross-section, it was a cross-sectional design, so it is the study captured in a snapshot of a time. And also some sort of confounding variables which we did not measure, which were, the nurses' diet, stress patterns, or even their pre-existing GI conditions are not controlled or, potentially contributing to their symptoms throughout the day. To close, our study reinforces that providers' well-being is not just about reducing burnout, it's about addressing fundamental needs, including gut health. Supporting our workforce in these simple but impactful ways will ultimately improve patient care. Thank you so much for listening.
Hello everybody. Welcome to the poster presentation on Silent Threat, Stronger Defenses. This poster describes a Legionella mitigation strategy for safer long-term care. Legionella pneumophila thrives in warm, stagnant water and biofilms, making potable water systems in hospitals and long-term care facilities especially vulnerable. Residents in these settings are often immunocompromised and severely at risk. A water management program grounded in ASHR standards and CDC guidelines is essential to reducing Legionella threat through proactive planning and control. A literature review noted that implementing environmental cultures and engaging infection control personnel in both evidence-based and cost-effective strategies for outbreak prevention in long-term care is essential. The purpose of this program is to eradicate detected contamination, both immediate remediation to remove Legionella presence and reduce immediate risk, and to ensure long-term prevention, that is to establish sustainable disinfection regimes and environmental control to prevent relapse. The advanced knowledge and readiness is also a purpose so as to train internal teams to recognize and respond and manage water safety hazards promptly. We also have to safeguard the vulnerable population. Both residents and staff benefit from a safer, rigorous managed water system. The purpose is also intended to set a sector benchmark by creating a replicable data information model for LTC facilities nationwide. The methodology adopted for this was one for the detection of Legionella contamination. The problem existed where environmental sampling revealed Legionella colonization within the potable water system, particularly at distant outlets like showers and faucets. Biofilm buildup and inconsistent disinfection levels contributed to bacterial persistence. The action was immediate system remediation using hyperchlorination and system-wide flushing consistent with CDC and EPA guidelines for rapid decontamination. A follow-up on the environmental testing confirmed a reduction of bacterial presence to non-detectable levels. Inconsistent water temperature control was yet another problem, and the storage and distribution temperatures intermittently drop below the threshold, needing to suppress Legionella growth. That is typically more than 60 degrees centigrade or 140 degrees Fahrenheit in storage, especially at the distal outlets. The action was to implement routine temperature monitoring and system calibration. Maintenance staff were trained to inspect and adjust mixing valves, recirculation pumps, and insulation to ensure consistent thermal control. Remote temperature sensors were being placed and piloted to enable continuous digital monitoring. Thirdly, insufficient residual disinfection level was a problem where free chlorine and chloramine residual varied across the water system, particularly in low-use wings, creating microenvironments for bacterial regrowth. The action was to establish automated monitoring of residual disinfectant levels combined with routine manual verification, consideration of a secondary disinfection system, including copper silver ionization and monochloramine to ensure stable biocidal conditions across the network. Now, with all of these, a thorough system change was implemented, and staff training was also rolled out to ensure appropriate information disseminated to all for the strategies in place to mitigate Legionella contamination. So thereby we were able to establish a very systematic protocol in controlling and managing our Legionella as part of the mitigation strategy. Now, we deployed a centralized digital log system to track water quality, data, corrective actions, and staff observation. This support evidence-based decision-making and facilitates reporting to stakeholders and regulatory agencies. Thank you for your attention.
Greetings to everyone at NAINA conference. This poster is based on a study, Reimagining Pedagogy, Anonymous Peer Review as a Catalyst for Engagement, Reflection, and Collective Learning. The study was conducted by Dr. Maya Joseph, Ms. Uma Maheshwari Venugopal, and Dr. Brenda Marshall. There is profound evidence in the literature that experiential teaching methods can significantly improve nursing students' skill for training, analyzing and solving problems, making appropriate judgments, and innovative thinking compared to traditional teaching. The study examined the impact of anonymous and low-stake peer review as a constructive learning tool in nursing graduate research courses. Coming to the methodology, the study design was a retrospective review of archived online discussion posts using a mixed methods design with a dominant qualitative content analysis system. Setting was an online course at a Northeastern public university. The sample included purposive sample of archived student discussion posts from 5 graduate level asynchronous 7-week research courses between 2021 and 2023. 105 narratives were included. All student identifiers were removed and responses were coded. We got the IRB approval for the study and then data collection started. The student discussion posts were collected electronically and coded by the developer of the course, who was one of the researchers. 10 posts were randomly selected by ChatGPT. Only the theme of engaged learning was predetermined. The 10 posts were distributed between the 3 researchers who independently identified recurring themes. 2 themes were matched by all 3. 105 narratives were then coded and thematic analysis was conducted by all 3 researchers. Data saturation was obtained by about 30 to 35 narrations. The results, there were 3 major themes emerged from the study as well as 6 sub-themes. The major themes were engaged learning, improved writing skills, and culture of collective growth. The sub-themes of engaged learning was enhanced knowledge of research and critical thinking. The sub-themes of improved writing skills were self-reflection and improved organization. The sub-themes of culture of collective growth were learning from others and providing and receiving constructive feedback. It was interesting that we also used AI to depict the relationships between these themes and sub-themes, and the pictures shown here are showing the connections between these themes. Practice implications for this study is for professional development and pedagogy improvement for nursing graduate level research courses. Sharing expertise is another factor, and learning how to best utilize AI in teaching and research. References are provided here. You can feel free to reach out if you have any questions. My number is 973-902-5133 if you would like to contact me. Thank you so much. I wish you all the best and have a great day.
Hello, my name is Lena Joseph and I am a cardiothoracic surgery nurse practitioner. Thank you for taking time to visit my poster presentation. Today, I will be discussing a quality improvement project aimed at enhancing patient care following cardiac surgery, specifically by reducing preventable 30-day hospital readmissions. Cardiac surgery is performed for a wide range of conditions including coronary artery disease, heart failure, faulty heart valves, aneurysms of major blood vessels, and abnormal heart rhythms. The most common procedures are coronary artery bypass grafting surgery, valve repair or replacement, the MACE procedure for atrial fibrillation, aneurysm repair, and the implantation of devices such as pacemakers or defibrillators. According to the Society of Thoracic Surgeons Adult Cardiac Surgery database, about 300,000 adult cardiac surgery procedures are performed annually in the United States. More than half of these are isolated CABG surgeries, while valve replacement and repairs account for another significant portion. Patients undergoing cardiac surgery are often older, frail, and living with multiple comorbidities. This patient population is particularly vulnerable to post-operative complications, making the risk of hospital readmissions very high. Studies show that roughly 16.5% of cardiac surgery patients are readmitted within 30 days, and many of these readmissions are potentially avoidable. These readmissions not only increase healthcare costs, estimated at over $250 million annually, but also place patients at risk for the worst outcomes and significantly increase stress for both patients and families. With that background in mind, let me explain the purpose of this project. The goal was to evaluate whether a 48-hour post-discharge phone call conducted by an advanced practice provider could help reduce readmission rate after cardiac surgery. The intent was not only to prevent unnecessary readmissions but also to improve the continuity and quality of care during that vulnerable early recovery period at home. This project took place at a 250-bedded community hospital in the cardiac surgery department. Patients are eligible if they were 18 years or older and underwent elective, isolated CABG or single valve surgery. Patients with more complex procedures, emergency surgeries, or those who are discharged to rehabilitation facilities were excluded. Now let us move on to the intervention itself. Within 48 hours of discharge, an advanced practice provider from the cardiac surgery team called each patient at home. During the call, the provider reviewed several critical areas: the patient's condition since discharge, their medications, dietary and fluid restrictions, physical activity, surgical wound healing, and pain management. The provider also confirmed home health services and reinforced upcoming follow-up appointments. Importantly, the patients and the families had an opportunity to ask questions and clarify instructions. The calls typically lasted about 30 minutes and were conducted on weekdays between 10 a.m. and noon after the routine interdisciplinary rounds. Calls were documented in the electronic medical record as formal telephone encounters. For patients discharged over the weekends or holidays, the calls were completed on the next working day. In terms of study design, this was a convenient sample of 32 patients, and the project lasted from July through October of 2022. The data was collected using a secure database and supported by the hospital's cardiac surgery coordinator. The readmissions were tracked using the electronic health record and verified during the patient's 30-day clinic follow-up visit. The script for the phone calls was adapted from the Agency for Healthcare Research and Quality's re-engineered discharge toolkit and is tailored towards cardiac surgery patient population needs. A simple scoring tool was created to assess readiness, though this tool was not validated formally. Now let's review the results. Demographically, the majority of the patients in the 2022 were male, with an average age of 61 years. This is consistent with the prior years of patient populations as well. Regarding outcomes, in the pre-implementation years of 2019, 2020, 2021, the 30-day readmissions rates were 7%, 20%, and 4% respectively. In the year 2022, during the implementation period, the rate was 16%. When comparing pre- and post-intervention data, statistical analysis using chi-square showed no significant difference with a p-value of 0.165. However, it is important to highlight what the numbers don't fully capture. During this project, patients and families consistently reported that the post-discharge phone calls helped them to feel more supported, less anxious, and better prepared to manage the recovery at home. Advanced practice providers also expressed satisfaction with the process, noting that it enhanced continuity of care and allowed early identification of concerns. Of the 32 patients, 5 were readmitted within 30 days. The reasons included wound complications, arrhythmia, chest pain, dizziness, and non-cardiac conditions such as acute cholecystitis and epistaxis. Importantly, these readmissions were considered clinically unavoidable, meaning they would not likely to have been prevented by a phone call alone. The average length of stay of these readmitted patients was 11 days, and all required additional diagnostics and interventions. This highlights the complexity of the cardiac surgery patient population and the reality that a single intervention may not be sufficient to fully prevent readmissions. In the discussion, while the 48-hour phone calls did not statistically reduce readmission rates, they offered several qualitative benefits. They served as an additional safety net, reinforced discharge instructions, and improved patient engagement. In an era where hospitals face penalties for high readmission rates, even a small improvements in patients' confidence and continuity of care are valuable. The project also revealed opportunities for further research, expanding this intervention to a larger patient population, multiple centers, or combining it with other strategies such as telehealth monitoring or structured home visits may demonstrate stronger impact on reducing readmissions. Finally, in conclusion, this project reinforces the importance of continuity of care after hospital discharge. Even when the readmissions are not preventable, a structured follow-up phone call provides reassurance, improves patient understanding, and strengthens the connection between patients, families, and healthcare team. At this point, I would like to acknowledge the cardiac surgery team at the Jefferson Northeast Hospital, Philadelphia, especially the director, Dr. Salil Shah, for their support and encouragement throughout this project. Thank you for your attention, and if you have any questions, my contact information is available on the poster, and I would be happy to connect further. Thank you.
Hello everyone. So this is about a research project that me and my co-researcher took in spring of 2024. We conducted a quasi-experimental study to find the differences between using a mannequin and a high fidelity mannequin and a standardized patient to teach cultural concepts to nursing students. And specifically, we chose 3 cultural concepts: cultural humility, cultural self-efficacy, and cultural competence. Many nursing and non-nursing organizations have called upon nurse educators to enable nursing students to take care of diverse patient population when they become nurses. And so this study was conducted basically to explore these 2 teaching strategies. And for our sample, we took total 97 students from 2nd year and 4th year baccalaureate nursing program in a university in Northeast Connecticut and the states, northeastern states. And we had 39 second-year student and 58 fourth-year student. It was a quasi-experimental pre-test, post-test design. And the valid and reliable instruments were used to measure all 3 cultural concepts: cultural humility scale, cultural competence scale, and cultural self-efficacy scale. And the students attended 15 simulations over the whole spring semester of 2024. They came in a group of 7 to 8 students each simulation. They attended a pre-conference, then simulation, followed by a post-conference. And the simulation was designed using NLN template, and it was a structured simulation. In the end, when we compared the results using rigorous statistical analysis, surprisingly, no difference was found between using a high fidelity mannequin or a standardized patient, although simulation again was shown to be a very effective method to teach cultural concepts to nursing students, because there was a statistically significant increase in post-test as compared to the pre-test for all three cultural concepts. But in between sterilized patient and high fidelity mannequin, no difference was found. And also side result that no difference was found between second year and fourth year nursing students, which was a bit concerning, because as we progress through the semesters and years in nursing program, the expectation is that there would be improvement in the cultural concepts of nursing students, but no difference was found between both of the years. And so now with this study again shown that simulation can be used as an effective teaching strategy for cultural concepts, but depending on the resources that a nursing program has, they can use either sterilized patient or a high fidelity mannequin to run these type of simulations. Few analysis, afterward analysis of the study were that our sterilized patient was a nursing student and a not professional actor. So if a nursing program chooses to use a sterilized patient, our recommendation is to use a professional experienced actors, and also extensive training in the field of cultural competence or diversity or any cultural concepts that they are working with, because our analysis was that the nursing student was not able to divert the conversation during the simulation session sometimes to meet the objectives of the simulation. For example, if the students are talking about the sensitive topic of discrimination and Tuskegee study, the professional actor should be well prepared to answer those questions, and again diverting the conversation to be able to meet the objectives of the simulation. Although our standardized patient did get a 4-hour training to run the simulation, but these simulations are not well structured, that there is legit dialogues, because sometimes the simulations are always dynamic, and we have to be able to be flexible during our conversations. But there are some limitations of the study, like we used a convenience sample. Due to demographics, there would be limited generalization of the study, and always self-reported data comes with biases. So for recommendation for the future research, we would recommend multi-site studies involving sterilized patient, and maybe providing the feedback to the student. Our sterilized patient was not involved in providing the feedback later on. Evaluation of student by SP to minimize self-reported questionnaire would be great. Simulation scenarios involving different types of diversity. Our simulation involve just the race and ethnicity component of it, but as we know, diversity is differences in humankind, so that would be great, and random assignment of the groups. Thank you.